thank you so much for all you do for the myeloma patient community, and for all the hard work that you do, keeping us all alive. We certainly appreciate that. And one of the things that came up is, there's much of a dichotomy about what high risk is. Some people say, well, it's based on fish. Other people say it's based on 70 gene profile. I heard that, well, anytime you relapse, you're at high risk, and when you're refractory, you're at high risk. If you have comorbidities like kidney damage, you're at high risk. So it seems like, could you please explain what high-risk disease is and why without a cure, low-risk disease will one day either morph or maybe morph into high-risk disease and become incurable?
Well, you're asking a lot of very good questions. I'm not sure I know all the answers, but I'll try to do my best. I think, first of all, I'd like to emphasize the fact that when we talk about multiple myeloma, we are for sure not talking about one disease. Also, I would like to emphasize the fact that even within one single patient, although we can set the diagnosis of multiple myeloma, there are multiple types of multiple myeloma going on already at diagnosis in each and every patient. I think that's very important to keep in mind, because when we give therapy, there will be differences in responses, in the duration of the responses and the long-term outcomes across individuals, but also within that same individual, there will be different responses across these different subtypes of myeloma, subclones of myeloma within a given patient in relation to a particular therapy. So if we try to make that very practical, what I just said, when we deliver the same therapy to every patient, if that were to be done, some people will have a good, someone will have a poorer response and duration of that response. And we will then call it high risk or standard risk disease. In my opinion, in the era of having an established curative therapy, there will not be any high risk disease. It's always going to be in the light of how any given disease is treated. And if you look back 10 years ago, 20 years ago, there would be more hallmarks of multiple myeloma, clinical hallmarks that would be counted to the category of being high risk. And as time is moving forward, that changes, because if you develop a better therapy today than you had yesterday, there could be some subtypes of disease that now would respond to this new therapy, which did not respond as well to the therapy we had before. So what I'm trying to outline here is that these are not written in stone inherent high risk versus standard risk features. These are always in light of how they are being treated, and they also are in light of what else is going on in the body. If there are different subclones, that will probably also impact. And the last thing I want to say as a starting point on this very topic is that when you treat a given patient with a given therapy, if that disease responds well, and you use whatever tools you use to call it high risk or standard risk, in the event, God forbid, the disease now comes back later and it has a different dynamic, it's more behaving more aggressively. If you were to apply those same tests again, and you would label it as high risk, it may be that those clones were there from the very beginning, and in fact there is scientific evidence to suggest that that probably is the case for the most part. But it's more a matter of the distribution of these different subsets of disease being shuffled around. So when you start off, you treat and you get rid of and you suppress those subsets of disease that are more prone to respond to therapy. So when the clinical presentation comes back, it's those subclones that did not go away to the same degree in the beginning, in the first place, that are now in majority. So the balance of these different subsets of disease have been shuffled around, and you are simply dealing with a new balance of subclones. So I think these are like fundamental principles of how very dynamic these dimensions are. There is no high risk and standard risk, and that's it. That's not how it works.
So would you say that high risk disease, or at least the markers, that we say we had one of the high risk markers, whatever it might be, and that it may not respond poorly, it might respond well, and actually the patient might do well? Well,
so as I try to outline, across individuals, if we apply a certain set of markers, and we can spend more time talking about what those markers are that people like to use, but as we are moving into the future and we monitor individuals, we will see that certain hallmarks of the disease do respond more or less to a given therapy. But there could be subsets of such features that are not so dominant. So when you work up a given individual, you may not see those markers because there are other cells that are more dominant. The disease has different subclones, so there could be subclones that don't have those hallmarks. But as you treat, you may bring down those subsets of disease that don't have the hallmarks of what you call high risk. But in the event that the disease comes back later, now these subsets of cells that have these hallmarks may be in majority, and you may interpret that as the disease has changed, but it's just the balance between these different subsets of disease that has been shuffled around. But if you have therapy that was tailored and designed to kill off these cells that are biologically in a certain way, then you would no longer call that high risk. You simply had a therapy that would kill off cells that have a certain hallmark, and you would now, on a clinical note, judge those as being standard risk. So high risk is only, in my opinion, a reflection of the fact that the standard therapy does not do a good job.
Okay, so it's just very difficult to define, and the definition changes with time.
Well, if you think about it, it's the marriage between biology and therapy. If there is a good match and the therapy depletes the disease, that's what we call standard risk. If that marriage doesn't work, then we call it high risk. And given that there are many biologies going on in parallel in the same patient, when you deliver therapy, if there are subsets of the cell of disease that have a very bad match to the therapy that's being given, that will be viewed as high risk. But in fact, it's the match between the therapy and the biology that is not there.
So in the end, we're all high risk because in the end, we don't no longer respond to therapy.
Well, so what I'm trying to say is like how it works biologically, but you could also take a very practical approach and say for someone who at diagnosis has a lot of those cells where very few therapies actually work, are those individuals more of a higher risk? Is that a correct statement? Yeah, I think that is a correct statement because you're now dealing with features of disease that impose more challenge, and there are fewer good options right away. So on a clinical note, absolutely, you could say that there are individuals who have a higher risk, and there are individuals who have a lower risk. But what you just said to me, I also think is right, that there are subsets of disease in each and every person that could be higher or it could be lower in the light of a given therapy.
Okay, thank you so much, Doctor. Now, is progress in high-risk disease important to the advancement of cure for all myeloma?
Yes, absolutely so. And I think that it's important for many reasons. So one key reason, I think, there are two key reasons that come to my mind right away. One is that for those individuals that are being diagnosed with a disease that is more aggressive, that would fall under the umbrella that we would clinically call high risk, for those individuals, we need better therapies to offer deep and durable responses, ideally to develop a cure. But we are not yet there. We are working to try to get there. But at this point, the key problem with the clinical hallmarks of disease that is more aggressive is that it may respond to therapy, but it's a little bit more prone to come back, and then we have to retreat it again. So it becomes a little bit of a hassle to deal with that all the time for the individual patient, that the disease tends to come back. So that's one of the key areas, I think, for clinical applied research, to try to come up with better therapies for those individuals. And if I look across the board of all the patients I see, I would say that is probably maybe 20 to 30% of all patients that are newly diagnosed that come to clinic that would fall into that category, around that number. Another area, I think, where high-risk disease discovery work is also very needed is for all the other individuals who do not fall in that category. And that would be for the reason you just brought up in your question back to me, if you say that every person potentially carries high risk. I do think for individuals who have more standard risk disease, that there probably could be a few cells that would be more of the high risk type. If we could get rid of those, that may be a step in the direction of trying to develop a curative strategy. So to deplete those last cells that don't go away with the standard therapy, to try to understand how that works and try to get after it. And it may be that those two goals actually are linked biologically and treatment-wise. So we need to do research in those areas, and it could have implications in the opposite direction, so to speak.
Okay, thank you. Along that same line, then, or following that, is what do you think is currently in the pipeline or on the horizon, either therapies or drugs, which will allow progress towards cure of high-risk myeloma?
Well, I think there are a lot of important efforts going on that I truly think have the potential to make major advancement, not only a few percent, but like major steps forward. I think that the development of cell therapy is important, using the chimeric antigen presenting T cells, the CAR T cells. That I think is a very new approach. Basically, what that approach is all about is to identify surface proteins on cells that are myeloma cells, and even earlier cells than the actual myeloma cells biology-wise, but to identify targets in terms of proteins, and then take out the individual patient's part of the immune system, to take out some of the T cells and reprogram them and give them back. And then they are now programmed to kill off cells that carry these proteins. So that's a very sophisticated way of depleting cells, and it has been found to be extremely successful, for example, in acute leukemia. There is also evidence in certain lymphomas, and there is ongoing work in myeloma now. The group at the University of Pennsylvania, led by Carl June, has done very interesting work. There is ongoing work at the NIH. We also have work going at the Memorial Sloan Kettering, and we will probably open up a full-fledged cell therapy program with CAR T cells in the coming year. I think that carries a lot of promise for high-risk disease. I think that many of the new drugs that are becoming available probably in the coming 6 to 12 months, they are now being reviewed by the FDA. They have also potential. I think that some of the monoclonal antibodies are very interesting because similarly to the first example I gave you with the chimeric antigen receptor cells, the T cells, these monoclonal antibodies, they go after surface proteins. So they are not dependent on certain genetic changes in the cells, or they do not work because there are or are not certain genetic changes in the cells. They look for things on the surface of the cells. And from all we know at this point, the high-risk disease looks similar in many aspects on the surface compared to the standard risk. So these new drugs could be a way to go after those cells that don't necessarily respond to medicines that target the internal features of the genetics of the tumor cells. From what we know right now, high-risk disease has ways to avoid the drugs that are delivered that target the inside. So treating on the outside, that's a new promising thing, I do think. And I also think that a third important thing, in my opinion, is the development of sophisticated monitoring tools for response to treatment and maintain deep response, specifically so for minimal residual disease detection. I think that has a lot of promise, and there are a lot of efforts going on trying to quantify very low levels and to try to rule out very low levels of detectable disease. I think that we will probably have at our institution, I hope in the coming 2 years, capacity to measure and rule out very low levels of residual disease, even by using just blood or even urine tests instead of doing bone marrow tests.
How great is that?
And I think that has huge potential, of course. You could see that that could change the whole game. So that's something we are pushing very, very hard for.
Would save my butt.
So I think those are probably key things, to use these new approaches with cell-based therapies and to integrate them with new sophisticated monitoring. I think they are potential game-changing strategies. But of course, they need to be further investigated, and then they need to be validated. So there's more work to be done. But I am very, very excited about these approaches.
Fantastic. Well, it sounds like some really great things coming up that put us closer than we ever have been to a cure. Now you're a member of the scientific board of the MCRI, the Myeloma Crowd Research Initiative. Why are you involved in this high-risk initiative, and why do you see it will have any better success at finding high-risk cure than the current processes?
I was invited by the founder of this program, Jennifer Ahlström, and I was fascinated by the fact that this is really driven by patient initiative. It's driven by modern, very dynamic thinking in terms of collecting funds this is like a group effort, and also the way the whole process is driven forward. It's very much driven by dedication and energy and focus on getting the work done. And I also think that the priority focusing on high-risk disease, I think that's very much needed. If we look at the past 10, 15 years of drug development in myeloma, we have shown and we have seen in many studies that survival has probably tripled for patients diagnosed with myeloma if we compare today with 10 years ago. And my projection is that it's going to continue to double or triple one more round. But importantly, that 20 or so % of patients that have hallmarks of high-risk disease, that group of patients has not really had a lot of benefit from all these new drugs. There are individuals in that group that do have, but on average, there is much less benefit in that group. So it's basically a group that was left behind. So there had to be focus on that group, and that's exactly what this funding mechanism decided to focus on. So I think that was the absolute right thing to do.
Okay. Well, thank you so much for your efforts with regard to that.